After this enriching session on personality development and leadership, we now proceed with the next session on business models and career opportunities in home healthcare. Home healthcare is a behemoth industry which shows no sign of slowing down. Opportunities explored in home healthcare, the senior today are showing a propensity for in-home healthcare compared with other options available. This inclination for home healthcare has not gone unnoticed by the entrepreneurs who are banking on filling this sizable demand, which is expected to grow significantly in the coming years as the massive baby boomer generation moves into retirement.
On that note, I would like to invite Dr. Gaurav Tukral, Senior Vice President and Business Unit Director in Healthcare at Home. A doctor turned administrator, Dr. Gaurav aims to create and bring a difference to the lives by creating a new vertical into healthcare, heralding an innovation in home healthcare. We welcome you, sir. I request you to address the gathering, sir.
Okay, I thought I was to come and sit first. I think you have just got the presentation. They'll take some time to put up the presentation. But I realized after the last session that a presentation doesn't work here. I have just 10 minutes to talk. I'll pick up from what my seniors said in the last session itself. I'll try to restrict my session to two parts. One is, as they said, the business model, where I'll talk about what Dr. Mahesh Joshi said, expert care. What is expert care and what is the perception of home care? And my second 5 minutes would be on the career opportunities, for which the whole gathering here is that how do you get to work with us? So I had the opportunity to discuss this with Afsha, who was very kind to me to get me from the airport. And I asked her that what is that you people want to know that what we do? And she said, हमें तो ये नहीं पता आप करते क्या हो, right? So my first part would be, what do we do? And second would be, what you can do with us. So out of all the challenges which got discussed in the last presentation, you know what is our biggest challenge? Our biggest challenge is not getting business. Our biggest challenge is not getting patients. Our biggest challenge is getting people to work for us. And that, if you think, is across healthcare, you don't have a skilled manpower. Just believe a person who's at home, who's privileged to be at home, who's alone, who does not have a senior nurse to ask for कि मैं क्या करूं, not a doctor at beck and call कि कुछ गलत हो गया तो doctor ठीक कर देगा, and I have to take decisions. And we know where our healthcare education systems are and what we churn out. And then we are talking of an eighth power person to do all that. And that's why I think that perception of a glorified maid is what home care was, right? 5 years back when I left Fortis and started this organization, I'm privileged to be the second person who joined Healthcare at Home India. I had to go and explain people what is home care. Today, 5 years down the lane, I'm privileged that I stand here where a whole day symposium is going on home care. So that's where the needle has moved. But as Dr. Joshi said, lots to be done. How do I change these slides? So, home care, everybody and anybody understands nurse at home. Okay? And I never understand कि वही patient जिसको almost 5 लोग hospital में treat करते हैं. You have a doctor who prescribes, a nurse who executes, there is a physiotherapist, there is a GDA, there is a dietitian, and whole end of so much staff in the hospital. वही patient जब hospital के gate से बाहर आता है, can everything be done by a nurse? Practically not possible. I am a doctor, 15 years into hospital. I think like a hospital administrator. I have run hospitals. So the first thing which we did in healthcare at home was build a hospital at home. And that's where we stand today. So I believe healthcare at home is trying to replicate hospital-like care, because the problem which we were all facing, Dr. Joshi said कि hospital से business क्यों मांगना पड़ता है? Hospital के लिए तो utilizations बढ़ जाएंगी if they have to push patients at home, and that's what is happening across the globe. Across the globe, in US, in Australia, in Europe, it's the insurance and the NHS or the government which is funding it. Clear-cut guidelines. TKR के बाद 3 दिन hospital में रहना, बाहर जाओ. Right? Go to a rehab facility or go home. There was an article in New York Times just 3 days back which says that they are not even sending a TKR patient to rehab facility, they are sending to home. Why not in India? India में तो मतलब उतने hospitals बनाने में ही पता नहीं कितना time लगेगा और तब तक population और बढ़ जाएगी. So home care is the solution, I would say, right? So how do we do it? And now I'll quickly jump to how do we make a hospital at home. So How is this working or not working? How do I make this work? It's working. Thanks. Sorry, doctor, not a technical person. इसको किधर करूं भाई? ये चल रहा है. So I'll not speak all this. Enough has been. Can somebody do it from there for me? Yeah, करते हैं यार. So I am not going to speak कितना क्या बिलियन 4 बिलियन 2 बिलियन जब आएगा तब पता चलेगा. Right? This is all maths. आगे चलिए. Next. That is what I said. For every problem which we have in, हमारे पास डॉक्टर नहीं, हमारे पास नर्सेज नहीं, हमारे पास हॉस्पिटल नहीं, सब कुछ मेट्रो सिटीज़ में है, टायर 2 में कुछ नहीं. I can go and build a ICU at home in a tier 2 city. From my offices in Ludhiana and Chandigarh, I treat patients in across Punjab. From my offices or my centers, I would say, we work in a hub and spoke model. From Delhi, we cover lot of Haryana and UP. From Bombay, we cover almost whole of Maharashtra. A patient who has been admitted into a Leelavati, when he goes back into his own tier 2 staff, उसके पास कुछ भी नहीं है. The fall is from hair to hair, and that is what we are trying to bridge. Next. There are 3 principles which will work. That is what at Healthcare at Home we believe. It is clinical excellence. Dr. Joshi touched it. The care has to be led by protocols, and that's where our promoters come into play. We are promoted by Healthcare at Home UK founders. They did it 30 years in the West, across Europe and Australia. They wrote the standards for CQC. They all discussed कि standards होने चाहिए. NABH, I am assessor on NABH. NABH is away from this. JCI, sir ने बोला ये implement ही नहीं हो सकता. हमारे पास क्या था? CQC के standards है, and as sir said, we adapted them to India. And all our people are working on those protocols. Not an easy job to do. We are just trying to do it. Second is customer delight. I was discussing with Dr. Joshi, what is in for the doctor? आज डॉक्टर को तो हर जगह से पैसे चाहिए और ड्यूली चाहिए, राइट? एक डॉक्टर को होम केयर में से तो कुछ पैसा मिल नहीं रहा, क्यों रेफर करेगा? इसलिए इट बिकम्स अ पेशेंट सेंट्रिक मार्केट वेयर ही वांट्स अ ग्लोरिफाइड मेड, राइट? बट इफ यू मेक द डॉक्टर इन द सेंटर ऑफ इट and the customer is happy, you don't need to put hoardings across. It's the patient and the doctor who will say, go to them, I trust them. They will look after your father better than what you will do. And the third is, as I said, today it is out of pocket, but things are moving. There are private insurance companies who are now funding home care also. Next. Yeah, this slide. So as I said, expert care. सबने बात करी 8th pass, GDA, attendant. What I am talking of a model is how you do a chemotherapy at home so that there is a 25% cost saving to a patient. A hospital can do chemotherapies only which can be done in the hospital. In UK itself, 70% of chemotherapies are being done at home for last 15 years. ICU at home. Do you need to keep a patient in the ICU जो सिर्फ tracheostomy पे है, जिसको intermittent BiPAP चाहिए, or a patient who's going to die and we know he's going to die, let's him breathe his last at home. Can we take these patients at home and free the hospitals and doctors to take care of people who need to be in the hospital? Average waiting time of a patient in Ruby Hall to get into ICU is 7 days. In Artemis, Delhi, 8 days. We are so much short supply of bed. If I convert the home bed into a hospital bed, doesn't it make a lot of sense? So that's where we are positioning us. That is expert care. And that is why if you see a service subset somewhere, somebody said 600 rupees for this. Our attendant cost for providing a person who's trained to take care of you when you are not on active ventilation, non-invasive ventilation, infusions would be around 2,000 rupees for 12 hours. And that's the cost which we invest to maintain that quality and clinical efficiencies. Next. So as I said, our biggest problem, where do I get people? I work like a hospital, right? So I need a doctor, I need a nurse, I need a dietitian, I need a physiotherapist. I need people who sit in the front office, reception. I need people who will do quality checks. Everything is required by us, like a hospital. We have our support center in Noida as of now. And the missing piece again is the doctor. क्या एक डॉक्टर के पास टाइम है कि वो हॉस्पिटल से टाइम निकाल के घर पे पेशेंट को जाके देखेगा? नहीं है. How we have tried solving this problem? There is a command center in Okhla in New Delhi where there is a team of intensivists sitting and they do morning, evening rounds and even 24-hour monitoring through remote monitoring devices as they were doing for patients in the hospital. So we said if you can manage patients in the hospital, please manage the same for us at home. 2 more slides. I have 2 minutes left. Next. Next, 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 next. Go to the last slide. Yes, thanks. This. So as of now, whatever I spoke was my first vertical with which we started. Healthcare at home works in 4 verticals. There are 4 business verticals which coalesce into healthcare at home. Hospital at home is acute care, where I get patients from ICUs, from HDUs, post-surgical patients, patients who need catheterizations, injections, or as I said, geriatric patients who are at home, right? That's my first vertical. My second vertical, where we are trying to touch population, is a diabetes patient. जिसको हर टाइम पे डॉक्टर के पास नहीं जाता है, बट देयर आर 100 क्वेश्चंस ही वांट टू आस्क. मेरी शुगर बढ़ गई, मैं क्या करूं? इंसुलिन लूं कि नहीं लूं? मैं पार्टी पे आया हूं, मैं क्या खाऊं? और अ कार्डियक फेलियर पेशेंट जिसको ये नहीं पता कि आज मैं पानी नहीं पीऊंगा इतना तो मैं फेलियर में चला जाऊंगा, राइट? So what do we do about the chronic diseases which don't get admitted into the hospital, right? So we are building a new system where there are people sitting, and technology based, they are the support system to the doctor and to patient to manage chronic disorders. Third is funding. So somebody has started funding. Pharma services have started funding services at home because they have also realized that patient is the king. Patient is at the center of thing, right? And they could never have this visibility. उनकी visibility कहाँ तक है? Prescription. डॉक्टर ने प्रिस्क्रिप्शन लिख दिया, सेल्स वाले को पता चल गया, उसने ऊपर रिपोर्ट कर दिया. प्रिस्क्रिप्शन लिखने के बाद क्या किसी ने वो दवाई खरीदी? क्या वो दवाई उसने ली? उसके बाद उसका क्या आउटकम निकला? इज व्हाट वी डू फॉर फार्मा. एंड द लास्ट इज distribution. Somebody has to equip that medicine at home. Why do I have a chemist shop? Hospitals have chemist shop inside them, right? Similarly, our hospital has their own pharma distribution across the country. If you have read, there are n number of positions. As of now in my organization, 250 vacancies are there. And I'm not talking of clinical vacancies. Leave aside, I was asking Krishna sir that how do we get clinical people? But this is all non-clinical. Sales, HR, finance, clinical quality, P&L holders, product development, everything. Thank you so much. I know the time is over.
Thank you, sir. I now request Dr. Samita Jadhav, Deputy Director, Symbiosis Institute of Health Sciences, to felicitate our speaker. We have with us Mr. Kumar Krishnaswamy, Group Head HR, Nightingale's Home Health. Mr. Kumar Krishnaswamy has been the Head Clinician Engagement and Global Lead HR Shared Services at Fortis Bangalore, apart from having been the Group Head HR Department at Wockhardt Bangalore, among many others. We also have with us Mr. V. Tyagarajan, the Managing Director of India Home Healthcare. He has held positions such as Thought Leader and Guide at Blue Engage, Founder and CEO at Cybrin Technologies, Executive Vice President at VisualSoft Technologies, among others. Our next speaker, Professor Dr. Arun Jamkar, former Vice Chancellor, Maharashtra University of Health Sciences, Nashik. Sir has played a leading role in curtailing swine flu epidemic in Pune and offered a leadership to Sassoon General Hospitals in establishing H1N1 isolation ICU, creating respiratory and ventilator care management, and large patient care facility for the critically ill. I would now like to request Mr. Kumar Krishnaswamy to address the gathering.
Good evening, all. Thank you very much for being, giving an opportunity. I must thank Symbiosis for it. And my association with Symbiosis is more than 10 years now. One thing I must admit, Dr. Erwadek is not there. It is not that I'm coming, off and on I visit this place, never been to the same campus twice. I think that's a kind of vision and that's a kind of growth he has created in this great city. And it's a great thing to be associated with Symbiosis. And it's a privilege for us at Nightingale to be part of this and part of a great institution called Symbiosis. Thank you. I represent Nightingale, and I'm from the HR. I'm been involved in this right from day one when we started. The company is called Medwell Ventures, and Nightingale is the brand. The brand Nightingale is 18 years old now. Probably, maybe somebody can correct me if I'm wrong, in the organized sector, the first company to be there, because it was in that space of organized home healthcare since it's almost 20th year now. Let me sort of, since I know there is a huge shortage of time, let me just give a glimpse of the kind of business model what we follow, and I will substantiate with a couple of slides. We are currently in about 4 cities, with Pune being the latest, which we opened a few days back. You must be seeing we are painting the town blue, which is our corporate color. We are driven by a branch model. We open branches. The branches serve, say, about 4 to 6 to 7 kilometer radius around the branch. And our primary, the aim in the business is, and which is something we have, I think, probably the first time, as of today, the only one doing it. And if you look at the stages, the entire thing is planned out, because we are very, very clear. This business generally, I mean, my earlier speaker also was referring to it, can be managed only if there is a clinical bedrock. We cannot move away from the clinical excellence. So that basically means medicine gets its due share. The paramedical plays as per the directions of the medical, well, fully supported by technology. Whether, all our staff, they carry tabs, or the back end is monitored in a common center, and further developments are happening in the technological space, which has got to be a fairly large team, in addition to the usual bells and whistles like the HR team, the customer care, and the other aspects of the business. So that's, and that's how it is. This is the base model, and it is delivered through branches. Our employees, all our staff, we have got about 1,000 employees across India today, 4 cities. They are all employees. They are either at some patient's house or in a branch. And the other supports like lab, equipments, whether it is CBAP or whatever it is, those kind of equipments, also we provide through the other agencies. Yeah, you can move. Yeah. This summarizes our basic offering, and it is an organized effort. We are very, very particular about the chronic condition management. Clinical outcomes are important. Our quality team, we have got a fairly large quality team supported by well-qualified doctors. Very, very clear. Outcomes have to be discussed, and any issues have to be corrected, which is what we feel will create a hallmark of an institution. And all other support systems like diagnostics, device, pharmaceutical partnerships are in place, because they are all required for a full-fledged treatment. The technology setup is there. We very, very particular in terms of recruitment. Yes, it's a challenge, and I'm happy that the Vice Chancellor of the university is also here. It's a big challenge for us, sir, to get the right people, because we are very, very particular that it has to be clinically qualified. Yeah. So that's a summary of model. You can go to the last slide and play this one. You can just have a look at it, and that summarizes my talk.
India faces a significant burden of chronic disease, where traditional healthcare systems cannot provide much support. The healthcare system in India needs innovations. At Nightingales, we integrated the customer, the clinicians, and the technology to help provide a 360-degree medical support. For the last 18 years, we have invested in creating a robust ecosystem wherein we have understood the needs of the patients. And we have built a team of professionals across various medical needs. We have defined various protocols, and we have developed the technology to collect EMR from various interactions, including medical devices, for delivering better patient outcomes. All carried out from the homes of our subscribers, with various parameters recorded regularly. Data collected and archived. Reports analyzed. And in cases of medical events, we recommend them to an expert. Let's assume a case of chronic heart failure. We recommend a cardiologist or electrophysiologist. The subscriber may undergo a pacemaker implant. Nightingale plans his home treatment protocol along with specialists, and after his discharge, we take him under our care. We follow up with the subscriber, manage the devices required, manage his wound, provide him physiotherapy, and review